So we're going to talk about four main things here. We're going to talk about planning a pregnancy, if it's right for you or your partner. We're going to talk about managing epilepsy throughout pregnancy, then looking at the postpartum period, and then for those who don't want to have a pregnancy, contraception and what the options are in that respect. So in terms of planning for pregnancy, one of the very first questions is, am I even able to have children? So childbirth rates are lower in people with epilepsy, and particularly women with epilepsy. There's an approximate 38% infertility rate, and if you look at the numbers, compared to around 70 per 100,000 people who have normal neurologic templates and do not have epilepsy, there's a 20 out of, sorry, I said that backwards, so 20 out of 1,000 women with epilepsy. I think those numbers are backwards. Basically, you have 3 times the risk of infertility if you have epilepsy, but infertility rates in the general population are still low, so you still, in the majority of cases, are able to have children when you have epilepsy, but there could be factors that impact your fertility. So this could relate to changes with hormonal regulation due to changes within your brain due to your epilepsy, side effects from medications, which can include things like premature ovarian failure or PCOS, or sometimes the medications that you're taking, particularly those that we call enzyme-inducing drugs, which we'll talk about more, may affect steroid concentrations, and that can all affect fertility for women. Men tend to have unaffected fertility. However, sometimes medications like carbamazepine, for example, can lead to low testosterone levels. So if you are a male with epilepsy and you're having problems with fertility and you're on that medication, it could be something that you should have looked into, because sometimes it's just a matter of being on some testosterone supplementation. So if I have epilepsy, well, my children also have epilepsy, and as you may know, about 1 out of every 100 people will develop epilepsy in their lifetime. So the risk for children whose father has epilepsy, it's only really very slightly higher than the general population. If the mother has epilepsy, the risk is still no greater than 5 times that of the general population. So we're dealing with an under 5% risk of your child having epilepsy if you take all comers. If both parents have epilepsy, then the risk may be cumulative and slightly higher. Most children, however, will not inherit epilepsy from a parent, and in general, it is not a reason not to go ahead and proceed with having a family if you're interested in doing so. As a continuation of that, if the cause of epilepsy is acquired, for example, you were in a car accident or had a trauma, or there was a stroke or a meningitis, these are things that you do not pass on to your children, and your children's risk of epilepsy will be the same as the general population, which is around only 1%. There are various familial epilepsy syndromes that have been identified, and the risk may be individualized, and you may have an increased risk depending on the cause for your epilepsy. If a genetic cause is identified, then genetic counseling may be sought. It's important to emphasize, though, that the antiepileptic drugs, that's what AEDs means for the rest of my talk, themselves do not increase the risk of epilepsy in children as far as we've been able to establish. What about brothers or sisters of children with epilepsy? Are they more likely to develop epilepsy? So yes, the sibling risk is slightly higher than usual. That's because there are genetic tendencies towards some of the epilepsy syndromes. However, most brothers and sisters do not develop epilepsy, and it's important to talk to your doctor around your particular epilepsy syndrome and whether there will be risks to other siblings. But usually that's not a prominent consideration for most people. So what should be done to prepare for pregnancy if you've decided you'd like to proceed? So it's important to work with your neurologist well in advance, just like we were talking with transition to adult care, same with this transition to the pregnancy state. You want to optimize your seizure control and your medications, and have things like baseline drug levels checked and stability in your control before proceeding with a planned pregnancy. And it's also very important to take folic acid supplementation, and I'll explain why. So this whole planning for pregnancy is about this scale. We're balancing the medication side effects with the risk of seizures to the infant or the fetus developing in utero. So what are the potential consequences to the baby if I have seizures during my pregnancy? So there is risk for fetal hypoxia, that's low oxygen supply, due to decreased flow of blood through the placenta, or for oxygenation of the mother after she's had a seizure, if it's a generalized tonic-clonic seizure. Sometimes studies have showed that the heart rate for the fetus will decrease, and that's been documented for up to 30 minutes following a generalized tonic-clonic seizure in the mother, or even sometimes following focal seizures that aren't generalizing to convulsions. There can, of course, be mechanical injury to the fetus if the mother falls, or there could be a placental abruption or a miscarriage due to trauma. And there are higher rates of major congenital malformations in women with epilepsy who've had more seizures in their first trimester of pregnancy. So we'll talk more about major congenital malformations, but for these reasons, it's important to try to minimize seizures during pregnancy. However, there's a lot of concern about medicine side effects, and a lot of women will ask if they can stop or decrease their medicines in advance of a pregnancy. And discontinuation of antiepileptic drugs may be considered in a small group of patients, people who've been seizure-free for 2 to 5 years, who have a single seizure type with a normal neurologic examination and intellectual functioning and a normal EEG. This is a group of people where it might be appropriate to consider decreasing and or stopping a seizure medicine in order to plan a pregnancy. In my practice, at least, although I'm a tertiary care epileptologist, usually we're looking at medication simplification or optimization as opposed to complete discontinuation while planning a pregnancy. It's important to keep in mind that the risk of seizure recurrence or reflection of your seizure control in pregnancy is best forecasted by the first 6 months after you've been off of a medication, if you're going to completely stop a medication. So it's really ideal to make these changes at least 6 months in advance of planning a pregnancy. So what is seizure control usually like during pregnancy? The rate of remaining seizure-free during pregnancy in women with epilepsy who are seizure-free for over 9 to 12 months is 90%. This is fabulous. So if you've been seizure-free, the chances are you'll stay seizure-free in pregnancy. There are, however, statistics that show that particularly in those who aren't necessarily seizure-free, who have drug-resistant epilepsy, that maybe we have to accept some level of ongoing seizure activity, that about 1/4 of women with epilepsy will experience an increase in their seizures during pregnancy, 1/4 will experience a decrease in seizures, and then the other 50% will tend to have no significant change. And this is provided that you're receiving active longitudinal follow-up by a neurologist who may need to adjust your medicines as you proceed, for reasons we'll discuss. So which are the better anti-seizure medications to take during pregnancy? Well, you're supposed to try to use the drug that's worked best for you. And this is based on your personal history and perhaps trial and error that you've already gone through. It's optimal if only one medicine can be used, if that's possible for your epilepsy syndrome, and the lowest dose that is effective is preferred. Of course, this has to be a drug you tolerate with minimal side effects. You should consider having drug levels checked before the pregnancy and monitored throughout. And if possible, we avoid polytherapy. That means more than one medicine, although sometimes we do need to use more than one medicine, and that can be just fine. It's important to avoid certain anti-seizure medicines that cause teratogenicity, which means risk of major congenital malformation in the baby. So what is a major congenital malformation? So these are structural abnormalities of essential anatomic structures that are present at birth and that are felt to interfere significantly with function and require a major intervention. That's why the word major is there. So if there's a little freckle on the right shoulder, obviously that doesn't count. If there's a problem with the way the mouth is developing and there's a hole in the roof of the mouth, then that counts. So overall, the rate of major congenital malformations is anywhere from 3 to 9% in women with epilepsy versus 2 to 3% in the general population. So this reflects an approximate 2 to 3 times increased risk. This risk is higher in women with epilepsy who continue to have convulsions during their pregnancy, as well as those who are on certain anti-seizure medicines that we're going to talk about, namely ones like valproic acid, as well as women who need to be on polytherapy during their pregnancies. The risk of major congenital malformations is highest in the first trimester of a pregnancy, and those most commonly associated with anti-epileptic drugs, the major congenital malformations are neural tube defects, And then on the side I have the date of gestation that this kind of malformation tends to occur. Neural tube defects means things like spina bifida, malformation of either the spinal cord or it can be cephalic, the brain. Congenital heart disease, cleft lip, cleft maxillary palate, and then some urogenital defects. You can see all these abnormalities tend to occur within the first month to 2 of a pregnancy. Oftentimes the woman may not even know she's pregnant by that point, or she's only just first missing her period or getting the testing done. The importance being that the impact of the medications is often those very early days that's most important. So here are some pictures and examples of some of the different types of major congenital malformations, including the neural tube defects, the changes with hypospadias, and then the cleft lip, cleft palate. The North American Antiepileptic Drug Pregnancy Registry is something that I always encourage my patients to register for once they do become pregnant, because this is a trial whereby we're open label asking every woman to report her pregnancy and the meds she's taking and answer some questions throughout the pregnancy and then afterwards, so we can get better data collected cumulatively to understand what the risks are for women with epilepsy and individualize these risks to any given drug. So here's an example of the data we have so far. It shows you the different anti-seizure medicines on the left column, and then on the right I've circled some of the common ones. As monotherapy, these are the rates of major congenital malformations. So you can see lamotrigine has a rate of approximately 2%. If you look down, topiramate back in, this is a little old, 2014 had a rate of 2.2%. That's since actually come up as we collect more data to be more towards 4.5%. And then some of these drugs look like they have low numbers, so you can see 1.2% for gabapentin. Well, truth be told, not a lot of women are taking gabapentin. You look at the number of reported pregnancies, and we're dealing with around 150 compared to 1,500 pregnancies on lamotrigine. So the point being that any one of these medicines on its own tends to have reasonably low risks of major congenital malformations. So valproic acid, which is quite notorious, up to a 10% risk of major congenital malformations almost. Phenobarbital is also one that we really try to avoid if possible. These are the trends in anti-epileptic drug use as monotherapy in women with epilepsy, and you can see over the years that the use of lamotrigine in blue has been highly favored and has been, my apologies. Lamotrigine is actually, I've miscolored these. Lamotrigine is the one that's shown in red, and so lamotrigine had been the highly favored agent used up to about 10 years ago. Then levetiracetam or Keppra came on the market, and it started to increase in its use, and now they're basically overlapping and tied. Both agents are highly preferable for use in women with epilepsy, if effective for that person, because they have lower rates of major congenital malformations. Oftentimes people ask if they will have their child's intelligence impacted by the use of their anti-seizure medicines. And it's felt that cognition is probably not reduced in the children of women with epilepsy who are not exposed to anti-seizure medicines. Likewise, it seems like for fathers taking anti-seizure medicines that this does not seem to have impact on their children. But for women who are taking anti-seizure medicines during pregnancy, there is some data to suggest that there may be lower IQ scores in their children, and this is particularly so for valproic acid or divalproex. It's also been shown to be less significant for drugs like phenytoin or phenobarbital, which are some of the older anti-seizure medicines. We don't have good data yet for the newer ones like levetiracetam or lamotrigine, which are getting used more often. In general, though, it's because of some of these concepts that we try to use lower doses of as few drugs as possible, and we do try to avoid the divalproex. This is just some data showing exactly what the numbers were in this trial that was done out of the UK, showing lower IQs in children aged 6 who had IQ testing done when their mothers were exposed to valproic acid compared to other anti-seizure medicines as monotherapy. Factors that also impact the IQ of the baby are whether the mother continued to have generalized tonic-clonic seizures during the pregnancy and whether the mom has low IQ, which certainly suggests there can be some additional genetic factors at play. So now you are pregnant and you've decided you're going to take these pros and cons of the medicines, and you've worked with your doctor to come up with a plan. So what do we do during pregnancy? So in general, there is no conclusive evidence that there's an increased risk of any kind of obstetric complications that would be a reason not to proceed with a pregnancy. Occasionally there are higher rates of things like miscarriages or need for more urgent deliveries or C-sections, for example, but this can relate to a number of factors that have to be individualized to your scenario. Recent guidelines are, however, meant to decrease anxiety for both the practitioner and the pregnant woman with epilepsy. As I mentioned earlier, 90% of women with epilepsy can expect to have healthy pregnancies and healthy babies. We do screening in women with epilepsy to look for things like neural tube defects with ultrasounds, as well as maternal marker triple screening. So it's important to get regular pregnancy care. A big question that often comes up is, should the anti-seizure medicines be changed once pregnant? And there's a lot of reasons not to change the medicines once you're pregnant. There are risks of precipitating seizures that can be up to 20%. There's the risk of major congenital malformations. That's usually that time's already passed by the time all of these decisions are being made. And if you're making changes, you're invariably overlapping drugs, using more than one at a time, which exposes that early fetus to the polytherapy that we're usually trying to avoid. There are times where the meds will, however, be changed, especially if your seizure control is declining or there are drops in your drug levels, and we're going to talk about this next. So why do the anti-epileptic drugs tend to have lower levels in the serum when you're pregnant? Well, there's all kinds of pharmacologic reasons I'm not going to go through. But basically, it's very well established that certain drugs, and particularly lamotrigine, will drop up to half in almost all or the huge majority of patients, and we treat expecting these levels to drop and monitor drug levels accordingly. So lamotrigine is the one where it's now recommended to consider monitoring up to monthly throughout pregnancy, and it's really important to check drug levels at baseline when your control has been stable, and then monitor monthly or at least every trimester, as well as at 36 weeks gestation, so as to make adjustments in the dosing accordingly. And in general, a woman who's reached approximately 24 weeks or starting her third trimester will often be on up to twice the dose of lamotrigine that she was on before she was pregnant, in order to ensure that there are steady drug levels in her blood. This is individualized, and if you've gone through a pregnancy and that didn't happen to you, well, it's not to say that you had to have your drug doubled, but level monitoring helps guide your physician with some of these decisions. Other times you might have monitoring done is if your control declines or there's problems with more drug side effects. Or sometimes your doctor will check the levels because they're worried you're not taking the medicine, for example. What about the actual labor and delivery? So the risks of a seizure during the labor and delivery are quite low, only 1 to 2% during the actual labor, and then a 1 to 2% risk within the 24-hour period afterwards. Vaginal delivery is still the preferred option. However, sometimes a C-section is considered, particularly if you've had very poor control with frequent convulsions or a history of status epilepticus when your body's been under stress in the past. I often get asked by women if they can have a home birth, and in general it's preferable for you to be in a hospital-controlled setting in the event that there was a seizure during the delivery or there were any problems with that actual progression of labor, so that if there were fetal decels or problems with the baby, that this was something that could be dealt with more urgently by physicians present. What can be done to decrease the risk of seizures during labor? It's really important to optimize your seizure control throughout the pregnancy. Make sure that you've taken your medicines throughout the stress of labor without missing doses or taking an extra dose if you happen to vomit it up. Rest as best you're able, and a lot of women, I do encourage that they give consideration to an epidural so as to help decrease the stress of the whole thing. And if needed, sometimes doctors will give IV anti-seizure medicine if the seizures do occur during labor. So moving on to postpartum epilepsy care, there's no contraindication to nursing your baby with epilepsy if you are a mom with epilepsy, and we encourage ongoing nursing independent of what anti-seizure medicines are being used, because the benefits are outweighing any risks to the baby. But we do know that babies are exposed to the anti-seizure medicines in the breast milk. This is not any more, if not it's less, than the concentration that the baby is used to getting while they're in utero, while exposed to the mother's circulation and the drugs circulating at that time. Sometimes babies will need to be monitored though for excess sedation or irritability or failure to gain weight if they're on or if they're getting exposed to certain anti-seizure medicines in their mother's breast milk, particularly the benzodiazepine medications or phenobarbital, because they tend to be more sedating. In my experience, I have yet to have a woman with epilepsy whose infant was significantly sedated by these medications, but it is something we watch for, and then if that's a problem, we may need to react. But it's the huge minority in my experience. And it's important to note that IQs have not been shown to be any different in children who are nursed as opposed to not. What to do with these anti-seizure drugs? If I've doubled your lamotrigine throughout your pregnancy and you deliver, now what? So all these changes in the pharmacology usually reverse within 8 weeks. It's hard to have a recipe to follow. Sometimes the medications, if they've gone up quite significantly, will drop it by about a third immediately, and then we'll follow with drug levels and or clinically, and depending on your seizure control and the drug levels and or sedation or side effects, this tends to be individualized, with the drug going back to its pre-pregnancy dose, usually within a couple of months or so. And lastly, I want to talk in the postpartum phase about seizure precautions, and this doesn't just apply to mom, it applies to dad too, of course. So if a parent has epilepsy, it's important that they not bathe their infant alone, that they try not to carry the infant up and down stairs or put the child at risk of being dropped. Sometimes that should say change baby on the floor as opposed to up on a change table so the baby doesn't drop off if the parent were to be unable to attend to them due to a seizure. And consider additional care to help avoid sleep deprivation. Refrain from driving if already seizure-free and able to drive. It's often cautious to take a break from that in the immediate weeks postpartum with sleep deprivation and hormonal changes. All right, so just ending off here, we're going to talk about contraception for people with epilepsy. I think this is a pretty cute picture. I don't know about you guys, but so what is the best contraceptive method for me? So this decision will depend on which anti-seizure medication you're taking, whether you want to have children in the future or not, whether you have other medical conditions, and whether you have religious or cultural beliefs surrounding the pregnancy prevention. The non-hormonal measures do not interact with anti-seizure medications, and these are listed in order of increasing efficacy, okay? So fertility awareness methods, this means you just monitor your cycle and only have intercourse when you are not ovulating, so this is the least effective. And then you can see listed here the varying different non-hormonal measures of contraception, all the way through to vasectomy and tubal ligation, which are permanent and irreversible measures. I'm going to show you a quick picture of the hypothalamic-pituitary-ovarian axis, so it's only to highlight that there are many steps along the pathway, starting up in the hypothalamus in the brain, moving down to the pituitary gland, and then down to the ovaries, as to where there are hormonal interventions that can impact a female's fertility. And of course, this is a graph showing that hormones will change, estrogen and progesterone levels, depending on different levels of the cycle. When women take exogenous hormones, what's happening is that they're usually suppressing their brain release of the sex hormones FSH and LH, which are normally needed in order for the ovaries to then ovulate. And this is a very simplistic view of how those extra progesterone and extra estrogen doses that women take in varying formulations work to prevent fertility. So there's this triangle between the effects of the epilepsy and the seizures, and there's all these double arrows, right? And that will sometimes affect sex hormones and fertility in women, as can their anti-seizure medicines. And the anti-seizure medicines can sometimes impact the sex hormones, and the word steroid is there because the estrogen and progesterone are steroids. So certain anti-seizure medicines, particularly those listed on the left column in bold, are strong enzyme inducers. That means that they make your liver metabolize the sex hormones of progesterone and estrogen more rapidly, so that if you're on the medicines listed on the left, the most commonly used would be carbamazepine or Tegretol or phenytoin or Dilantin, for example, then these are the drugs that are going to very significantly decrease the efficacy of any kind of hormonal contraception. Then there's drugs listed in the middle that are weak enzyme inducers, and that includes lamotrigine. and topiramate. And then on the right, there's a whole list of drugs that don't interact with hormonal measures. So what contraception should I be using if I am on one of those bad ones, one of those enzyme-inducing drugs? So an intrauterine device is preferred. A Depo-Provera injection could be considered, which is a progesterone only once every 3 months, I think. Progestin implants are newer on the market and may be an option for you. Or if you choose to use an oral contraceptive, you need to do so with an additional backup method. So the IUD is by far my favorite. This is clean, it is extremely effective, it is cheap. It ends up costing you no more than $6 a month, and it is reversible, and you don't have to worry about anything with your drugs, and I do strongly encourage its consideration. Depo-Provera is another alternative given IM intramuscularly every 3 months, but there are risks of low bone mineral density with this, and I don't have many patients in my practice who use Depo-Provera. The progestin implant is a newer thing whereby a physician is able to insert this little tube, which actually has an amount of progesterone that will last up to 3 years. And it's sort of like the Depo shot, but it's actually a full 3 years worth. This seems to potentially be an option, but we don't have as much data on it. And then finally, because the combined oral contraceptive pill or the birth control pill is so commonly used, it's important to emphasize that whether this is right for you or not is going to depend a lot on your particular anti-seizure medications that you take and whether or not you're having problems with breakthrough bleeding. Sometimes an estrogen low mini pill is really not a good choice for you because that is a risk I find in my patients with epilepsy for decreased efficacy compared to if they have a regular dose of estrogen, which is 30 to 35. The progesterone-only pill may be used if you've been on that before. It's often used in women with perimenstrual seizure fluctuations because progesterone seems to be a protective hormone and decrease the risk of seizures. It's less efficacious though, and you cannot use it for contraception if you're on one of those enzyme-inducing anti-seizure medicines. It's often used post-partum because women can still lactate on this, although it may not be adequate as a sole form of contraception in that case. And this particular pill will have strong interactions with lamotrigine and will decrease the serum lamotrigine level significantly. And on that note, if you take lamotrigine, I do have a slide on this because so many women with epilepsy planning pregnancies or who have been pregnant are on lamotrigine. While we don't think that the lamotrigine significantly impacts the efficacy of the birth control pill in a large majority of patients, there is some suggestion that this can decrease the progesterone from the pill by about 14%. It's hard to know if that's clinically meaningful. But what is very well established is that there is a risk of when you are on the pill or you start it, that your lamotrigine levels in your blood can drop by up to 50%. So if you're going to start the birth control pill and you're taking lamotrigine, you should talk to your neurologist and your doctor prescribing the medication in advance to get your lamotrigine levels checked. And sometimes we'll preemptively increase your lamotrigine before we add in that extra hormone because it can lead to breakthrough seizures. And then sometimes people will use emergency contraception if you're going to use this morning after pill is often what it's called, and you're using one of those enzyme-inducing anti-seizure medicines, you need to take twice the usual dose or else it's not going to be effective. So in conclusion, most people with epilepsy are able to have healthy pregnancies and children, particularly with proactive, regular medical follow-up. It's important to work with your physician to optimize your seizure control and your medications prior to, as well as during pregnancy. And it's important to take folic acid 1 to 5 milligrams daily. I think somehow my slide on folic acid did not get included, but the folic acid is to decrease the risk of neural tube defects like spina bifida. Varying contraceptive options are available and should be individualized to your circumstances.